So one of the things that we're going to do, I was hoping to do today, is talk about some application, right? Some ways in which we can bring this into our work, into our lives, but particularly, there was one situation that came up. Somebody asked me yesterday, basically around how do you, let's say you really see that mindfulness can be helpful for a patient, a client, even a family member, and how do you get them to do it? You don't. This is part of that, the equanimity, the emotional balance of our job, is what I think and what I have seen to be true is that we can hope for the best for our patients and clients and family members, and we can help to the degree in which they are willing to do the work. But we can't make people change. Unfortunately, there has to be the balance between negative consequences and motivation to change. So one of the things that I have done and that I have begun to work with, and this is, I know you guys had some motivational interviewing training, and so using motivational interviewing to reality test, to roll with their resistance and not push, because oftentimes what you're going to have is the pushback. And then also patience, because there's always a moment of clarity, a moment of, okay, well, what you were doing hasn't worked. Are you willing to try something different? They say yes. How about we sit and we do some meditation for 5 minutes? How about we practice some of these DBT skills? How about you take this, this handout home and you fill it out? These different things. Right? How about you use this diary card to write down when you're having arguments throughout your day, throughout your week? So these are some different strategies that people use, that I use. So how about we just open up for, is there any of those kind of questions? It's like specific, kind of applied, not that I have the answers, but I'll definitely try to address from the mindfulness and the DBT perspective how we can utilize some ways of working with difficult clients or applying this. I want to kind of hear from you if you have specifics. Yes?
So one of the things that I notice in the practice here of psychotherapy is that there's this intense need to stick to a guideline. Mm-hmm. And then changing it, flipping it around, or it's a little difficult to do. Mm-hmm. Now, you've taken us through this experience, and it is, I appreciate it. How do you see that being applied to when if they want to use it on their patients? And since there's no sequence that I see here.
Mm-hmm. So you mean as far as like implementing it as a like a service plan?
Yeah.
Like a treatment plan?
Service treatment.
Actually, it's totally applicable in that way. And it's just like we do in any service plan. That's I think you're talking about service plans, treatment plans, this kind of setting so we can have outcomes and see whether it's been helpful and we're achieving like a 6-month outcome or a year outcome.
More like giving them a session by session. This is what you're going to be applying, or let's say DBT, like giving them, let's say, a cycle of. Okay, you're going to have a group of every 3 months, the group is going to cycle by itself.
Right.
Whichever phase you enter into, then you're going to go through that cycle, and then you're going to exit it while, depending on how the result comes in.
Well, DBT, so I'll answer this two ways, and then I'll get to your question, sir. DBT has it's a very structured, actually, very dose-oriented. There's, it's 8 to 10 weeks, and same with MBSR. And what I'm doing is actually giving you some fundamentals of both of those, but not the specific structured. Because it's whether it's done in individual, or whether it's done in group, or whether it's done in class form. There's a beginning, there's a middle, there's an end. And the same thing can also be true in an 8-week, so basically it's like an 8-week course. There's an 8-week course of MBSR, where it starts in one, and I actually have a full training for that, but again, it takes 10 weeks to do an 8-week training, because you go through it, right? And then once someone goes through it, then they're certified, and so on and so forth. And DBT, I actually do have one resource that I'm going to give you guys as a possibility, and a lot of what's here and in the book is also, it's very kind of systematically laid out, where you're working on mindfulness 1, mindfulness 2, distress tolerance, emotional regulation. So you're actually working on you're building on these skills. So you can definitely either do segments like mindfulness for 6 months, and then the next treatment review or whatever, so that kind of way. Or you can just do them incrementally, like, client will, like if you're talking about writing clinical doc and backing it up with clinical documentation, client will, engage in mindfulness meditation as a form of stress reduction and coping skills, dosage of 3 times per week for 6 weeks, and then clinician will reevaluate. So it's just how you word it, right? It's always the trick with this kind of system. But you can definitely, so like I said before, 10 to 15 minutes, 20 minutes optimally, that's very challenging. We just meditated for 10 minutes. That felt like a long time. Yeah. So that would be one way I would think about it. DBT, very structured. If you're gonna utilize DBT, you really need to utilize the whole structure of DBT, have it be as a group. I actually don't do that. I use mindfulness and DBT like I'm presenting it to you. So dialectical behavioral therapy it's very protective of the evidence-based, starts here, ends here, there's a known and predictable course. And it's usually about 8 weeks. So MBSR and DBT. And so the idea is that you would incorporate that, and then you would have a beginning of a class, and you would refer people that maybe you've identified as maybe a BPD or substance users. People with eating disorder. Yeah, exactly. People maybe are having some bipolar. They're medicated, and they're having some bipolar symptoms. And so you're going to give them other coping skills. All of these kinds of, this would be where the referrals come from. And then they would start that group, and then you can evaluate at the end of the group, 8 weeks. And then maybe they'd go through the group again. Maybe they would go on to another level, like more of a process-oriented group.
And do you have recommended tools on how to evaluate them in the beginning and the end, just so, out of curiosity, or?
Yeah, that's an interesting question. In MBSR, there is a before and after self-survey. And when I have studied specifically, because I did when I did my postgraduate work, around particularly applying mindfulness, MBSR, and this loving kindness practice with severe and persistent mental illness. And so we did a pre and a post with their self-reports. Reduction of symptoms, what are they noticing? Are they sleeping better? These kinds of things. Are they going longer periods of time without thoughts of self-harm, things like that? Pre and post self-reports is the way generally it's used. DBT, I'm not specifically sure if there is a pre and post outcome scoring or anything like that. Does anyone know that, whether or not there is? I don't know offhand, around that, to answer that particular question. So I want to get to this.
What the MBSR
No,
stands
I'm
for?
sorry.
I was going to ask you to repeat his question.
Oh. I'm sorry. Yes.
What the MBSR stands for?
NBSR, mindfulness-based stress reduction. And the question, sir, was, and I'm sorry I didn't see your hand, so I saw it sooner, but I thought it was another question. The question was specifically about, are there any kind of measurable ways to prescribe these particular skills that I've been working with? Are they measurable? Is there a known and predictable course, dosage, this kind of thing? And actually, that's what I was talking
What I was alluding to is, let's say, some of the practicing clinicians, like you and I know there are a few back there who are hiding, but I want to ask them, do you see yourself, like if I refer you a borderline personality, do you see yourself using MBSR in a structured way at this point?
I think it will all depend on the client and how apply it to him or her in particular. I could totally tailor it to the needs of the client.
And that actually, so tailoring it to the needs of the client is actually the way that I've been presenting this information. Is that the idea is to give you the understanding of the tools and the skills, and then allowing you to then see how it works for you. And really the invitation is for you to take this practice on for yourself as a way to help you engage more in a therapeutic relationship from this mindfulness perspective. And then through that, beginning to you'll find your own ways to implement it, like I have found ways to implement these into certain cases. Certain cases it just won't work. But I actually think that it can be very helpful for just about every patient that you probably see. Yeah. So we have a question in the back, or a comment?
With the same conversation that you're having, the challenges that I've seen, are you able to hear me?
Yes.
I'm able to hear you. Yeah.
Oh, okay. The challenges that I've seen with clients in general, when I'm trying to reinforce mindfulness, I think it's something great. But what I see that a lot of people get challenged, especially with teenagers, is silencing the mind, being able to look within,
Yeah.
not judgmental, and with the ethical that you're talking about. Would you suggest that we can help and guide them through this in order to at least, because I think if they were to try it a couple of times and really see the benefits from it, they would use it. And it has worked with some, but not most.
So like I said before, so the question, if you didn't hear, is around, so sometimes this is a difficult thing, and the concept of silencing the mind and looking within is foreign and challenging, especially for people that are in distress. And yes, that's very true. And so how do we work with that, right? My suggestion is take risks. And to just keep going to, I find that this mindfulness is really helpful. And you know what, when I get stressed out, normalizing that stress happens. And I used to think that meditation meant that I had to silence my mind. But then I realized that that's actually not true. That it's actually, can I just be with my mind? So it's finding different ways to engage. And actually we're talking about just normalizing behavior, normalizing these kind of, that they're human, right? And then this is that place of relating, especially with young people. Young people, I was once told you have 10 seconds with a young person. When you first meet a teenager, you have 10 seconds before they either write you off or they'll at least give you another 10 seconds. Right? And I just think it's totally true. Yeah. Sometimes you can buy yourself, a day or two if you just kind of allow, like you don't try to engage, you just allow, right? So this mindfulness practice, I think, we have to look for our opportunities. Right? The other thing I think is just to be brave. This is why I'm saying practice yourself, because if you know the benefits for yourself, then you'll be much more likely to actually go, you know what, you might want to give this a try. And that's basically the way I do it. You know what, you might want to give this a try. If you're willing to do it, I have a bell in my office. I go, let's just sit for a few minutes. I'll give a little bit of guidance. You don't have to close your eyes if you don't want to. Let's just sit here. And then see what happens. And then most of the time, I actually find they'll do it. You know, I've worked in some of the most, in my area, some of the most challenging schools, right? Dropped out kids, kids that have been kicked out of the main school system, lots of behavioral problems, lots of drug and alcohol addiction, gangs, you name it. Rural, underserved population. And just saying, okay, this is just what we're going to do. And having 50, and there was a time I had 50 students. So about as many people as here. 50 high school students everywhere from 14 to 19. Sitting for 20 minutes a day. And there was some miraculous changes. I still run into those people. They're like, hey, it's the mindfulness guy. I used to be the drug guy, so now I'm the mindfulness guy. Yeah, it's helpful. Yeah. So, but part of that just comes from my own. It just came from my own practice, and then other people like in the school system recognizing that. Yeah. It's a great question. Yeah, around how do we do this? We just try. What's the worst thing they're going to do? Be like, that was lame. Okay. But was it helpful at all? Oh, okay, it was helpful. Please.
I think it's like anything else, what you were saying about you have to be confident in it yourself.
Yeah.
To then in turn convey that confidence.
For sure.
To the other person.
Right. Which was one of the intentions when I spoke with Cindy about coming and doing this practice, or doing this training, was that particular focus of, taking this practice on for yourself. At least have an understanding about it. Any other thoughts, questions come up? Yes.
Okay, so mindfulness, it's an evidence-based. It's everything that you presented is...
Mindfulness-based stress reduction, MBSR, is an evidence-based practice.
Okay.
DBT, dialectical behavioral therapy, evidence-based practice. Both are research.
So here in behavioral health, some of the rehab technicians, they provide CBT interventions, the cognitive behavioral techniques. And the clinicians, they are providing different types of modalities, such as the cognitive processing therapy, the depression treatment quality improvement, the trauma-focused CBT, in addition to just the foundation of CBT. So everything that we have been learning these 3 days is something that it's going to help us become better clinicians or rehab technicians, and at the same time incorporate all these tools into all the modalities that we have been trained.
That you're currently using. That's yeah.
Yes.
It's both and is my way of saying both and. Yeah. We have lots of tools. We all have tools. We have personal tools. We have professional tools. We have life experience tools. Like I was saying before, we all have gifts. We have to figure out how we can offer those gifts to other people. And not everyone's going to take our gifts. It doesn't mean we stop offering them, right? But we have to find out what works. Yeah. And what works for you. Maybe it's a little, like for me, trauma-focused. I like somatic-based. I do a lot of somatic-based, a lot of body-based trauma work, trauma release work, using mindfulness, using DBT as augmentations to that. So, yes. Yes, last one, and then I'm going to go through a couple slides.
Okay, the thing is, this one thing I've been trying really hard for the last many years to implement in our department, the DBT.
Mm-hmm.
But the one thing I always heard is being given the answer that's too long. So what you are saying is 8 to 10 weeks it takes.
Yeah.
So
8 to 10 week group process, yeah.
So
Individual work can be either longer or shorter.
So how much is the shortest? Because when I asked that it's because we have a huge population of, borderline and a lot of, and I tried really hard to convey the message that we need it. But
Right.
every time the same thing being, I don't know if I see the thing differently or the department sees the thing differently. but I didn't have really hard to convey this message that this is the need, we need to do it. But I feel like this is the time. Maybe somebody's here in the group. I mean, of course it's for us, and I understand that. Basically it's for us. If we know it, then we can do it. But at the same time, it's applied mindfulness is for the patients too. So
Yes.
hopefully,
Yes.
we might be able to implement it if it's not that necessarily too long.
So let me just kind of reframe the question and repeat the question. So the idea of DBT being too long, the doctor was talking about implementing and wanting to implement for some time, but there's been a little bit of pushback or blowback. So the idea is of dialectical behavioral therapy is that it's been researched at a particular dose, and you wouldn't give a smaller dose, or maybe you would, but you would try it the initial dose, and then you would either you have to work with that, right? So that's the way I look at it, is that try it at the initial dose. That's what's been researched, evidence-based, and I don't understand why the powers that be wouldn't want to do an 8-week group, or a 10-week group. Because, I mean, if you think about it, these problems aren't going away. And so what's 8 or 10 weeks? Maybe the clients or the patients won't buy into it for that long. Maybe, but that doesn't mean we don't do it. We don't just do what they're doing. We're not just reacting to clients' non-participation, right? So if we want to create change in a system, we have to do what we think is right as a system. And so my encouragement is to try it. If it doesn't work in a year, if it's the outcomes are not helpful in a year, well then maybe change the dosage some, or do what you can, right? This is basically what I've done. But also the clinic that I work in, it's just part